Greetings from Eye Infirmary. Today we will present to you a case of soft posterior subcapsular cataract in a young male being taken up for manual SICS. The surgery starts with minimal conjunctival peritomy and cauterization. A partial thickness scleral incision measuring around 3.5 mm is marked, supplemented with Blumenthal side cuts. Sclerocorneal dissection starts in the center of the incision with a crescent knife moving towards the peripheries, dissecting the tissue as you come back. Here, the side pockets have been designed for a totally different reason. In our cases, we have noted that the fibrosis occurring in these pockets prevents the sag in the tunnel and reduce the SIA. The patient being operated works on a microscope, so total emmetropia is being aimed at. The other eye operated 2 weeks back is 6/6 unaided with an acceptance of 0.25 diopters of cylinder. Side port entry is made at around 90 degrees from the main tunnel, capsule is stained with trypan blue, and anterior chamber is formed with viscoelastics. An oval continuous curvilinear capsulorhexis is what we aim at in any grade of cataract. In soft cataracts, oval rhexis prevents any entrapment of the fluid between the PC and soft cortex that may lead to opening up of the capsular bag. At the same time, an oval rhexis covers the optic of the IOL, providing it stability. This aids in easy prolapse of the nucleus-epinucleus complex without any stress on zonule or compromise to the posterior capsule. This would otherwise refuse to engage into the dialer and is difficult to prolapse. A gentle hydrodissection is done with 26-gauge cannula and the nucleus is tapped on the opposite side to release the trapped fluid. In soft cataracts, we shift to visco cannula at this step. Visco doesn't let the AC collapse immediately and keeps a cushion effect on the PC as we prolapse the nucleus and epinucleus out of the bag. Again, the technique for delivery here too is visco expression. This not only reduces the number of instruments going into the chamber, but doesn't allow the AC to collapse at any step. The endothelium remains well protected. Irrigation aspiration is started from the main tunnel and areas that cannot be reached from the side port are cleared. Rest of the irrigation aspiration is continued from the side port. Ensure removal of every hidden chunk of cortex in every case. Posterior capsule was clear and PC polishing was not attempted in this case. This is another advantage of cortical cleaving hydrodissection. Notice here that how patiently the cortex is aspirated. As soon as the vacuum in the SIMCOS breaks, there is a surge that can lead to PC tear, prevented by slow and steady aspiration of the engaged cortex. Anterior chamber is formed with viscoelastics. A hydrophobic IOL implant is just glided into the AC with lens holding forceps, holding the lens optic in the periphery very delicately. In SICS, we prefer not to use the injector. The IOL is aligned parallel to the oval of the rhexis. Haptics stabilize the lens at 2 points 180 degrees apart, and the perpendicular parts of the optic is stabilized with rhexis margin. A thorough visco wash is mandatory. Clear every bit of visco from any part of the eye, the anterior chamber, posterior chamber, from behind the IOL, and lastly from the endothelium. There is absolutely no need to go behind the IOL with the cannula in every case. Just gentle tapping and rotating the IOL with the SIMCOS cannula will bring out the visco to the anterior chamber. Side port hydration is done to make the wounds watertight. Here the IOL required minor centration and adjustment after side port hydration, and that was done with Simcoes only. The chamber was again formed with BSS. Titrate the IOP so that the wound doesn't gape, leading to high surgically induced astigmatism. Repose the conjunctiva well. Do not leave the scleral wound bare, which will increase the chances of wound site infections and foreign body sensation in the post-operative period. Thanks for watching. Regards from I Infirmary Nabhat.